Did last time by saying that acute inflammation either resolves, repairs, or, if the cause isn't eliminated, transitions into something else entirely. Today, that something else is our topic. Chronic inflammation. Chronic inflammation isn't just acute inflammation that's been going on longer. It's a fundamentally different biological process with different cells, different mediators, and different tissue consequences. And with chronic inflammation, there's a specialized architectural response called the granuloma, one of the most diagnostically important structures in all of veterinary pathology. No contrast. Acute inflammation is fast, loud, and neutrophil driven. You can see it, you can feel it. Chronic inflammation is slow, quiet, and macrophage driven. The cardinal signs are often absent, which is why it can smolder undetected for weeks or months. The tissue consequences are also very different. Acute inflammation causes temporary damage that can often heal cleanly. Chronic inflammation causes ongoing, cumulative tissue destruction, and the healing response runs simultaneously, producing progressive fibrosis that can permanently alter tissue architecture. This is why chronic hepatitis leads to liver cirrhosis, why chronic interstitial nephritis leads to end-stage kidney disease, and why chronic airway inflammation leads to irreversible remodeling. Why does inflammation become chronic? The answer is almost always the same. The cause hasn't been eliminated. There are three main scenarios. First, a persistent infection caused by organisms that are very good at evading or surviving inside the immune system. Mycobacteria are the classic example. They live inside macrophages and resist destruction. Second, immune-mediated disease, where the immune system is reacting to self-antigens or to harmless environmental antigens. There's no pathogen to clear, so the immune response never gets a resolution signal. Third, non-degradable foreign material. If a macrophage can't digest something, it will keep trying indefinitely. Understanding which pathway is driving the chronicity is the key to choosing a treatment. Neutrophils are the infantry of acute inflammation. Macrophages are the generals of chronic inflammation. They don't just fight, they organize. They present antigens to T cells, which amplifies the adaptive immune response. They secrete cytokines that sustain the inflammatory environment. They keep trying to phagocytose whatever triggered the response in the first place. And, critically, they release growth factors that stimulate fibroblast, which is how chronic inflammation produces fibrosis. Think of a macrophage that has ingested something it cannot digest. It's stuck. It keeps releasing enzymes and signals trying to deal with a problem, and those signals keep recruiting more cells and stimulating more fibrosis. A frustrated macrophage is essentially a chronic disease generator. Inflammation has a characteristic cast of cell types, and recognizing them on a slide is a core diagnostic skill. Macrophages are large with abundant pale cytoplasm and a kidney-shaped nucleus. Lymphocytes are the small, dark, round cells you'll see in nearly every chronic lesion. Plasma cells have an eccentric nucleus with a distinctive cartwheel or clock face chromatin pattern. Eosinophils have that distinctive bilobe nucleus and bright pink cytoplasmic granules. Their presence should make you think parasites or allergy. And fibroblasts, those spindle-shaped cells embedded in collagen, are the architects of fibrosis. When you see a mix of these cells on a histology slide, you're looking at chronic inflammation, and each cell type is a clue to the underlying cause. Granuloma is one of the most architecturally beautiful structures in pathology and one of the most diagnostically useful. When you see a granuloma, you immediately know several things. 1. The cause is something that macrophages can't eliminate. 2. The immune response involves T cell activation. And 3. The inflammation has been going on long enough to organize this structure. The center contains epithelioid macrophages. Don't be thrown off by the name. They're called epithelioid because they're large and pink and vaguely resemble epithelial cells, but they're absolutely macrophages. Surrounding them, you'll often see multinucleated giant cells. These form when macrophages fuse together, essentially creating a super macrophage to try to engulf something too large for a single cell. That elevates your diagnostic thinking considerably. The type of giant cell tells you something about what caused a granuloma. Langerhans giant cells, where the nuclei are arranged neatly around the periphery of the cell like a horseshoe, are classically associated with mycobacterial and fungal infections. They're a hallmark of tuberculosis and related disease. Foreign body giant cells have their nuclei scattered randomly. The macrophages fused in a disorganized rush to surround something large and indigestible, like a piece of suture or a plant awn. Tauton giant cells have a distinctive ring of nuclei surrounded by foamy, lipid-rich cytoplasm. You see these in lipogranulomas and xanthomas. These aren't random variations, they're mechanistically driven, and reading them correctly narrows your differential diagnosis. Let me ground the granuloma concept in real veterinary diseases. Johne's disease in cattle produces a spectacular granulomatous enteritis where the intestinal wall is packed with epithelial macrophages, literally stuffed with acid-fast bacilli. On a ZN stain, those bacteria light up bright red inside the macrophages. Bovine tuberculosis produces classic caseous granulomas with Langerhans giant cells. Finding these at slaughter inspection is a major regulatory event. Blastomycosis in dogs produces pyogranulomas with that distinctive thick-walled, broad-based budding yeast. Histoplasmosis is different. The yeast is tiny and lives inside macrophages. FIP produces a very distinctive perivascular granulomatous pattern. And Pitheosis produces eosinophilic granulomas around gray-white Kunker lesions in the GI tract. Fibrosis is how chronic inflammation leaves its permanent mark on tissue. When macrophages are persistently activated, they keep releasing TGF-beta and PDGF, growth factors that drive fibroblasts to proliferate and lay down collagen. Over time, collagen accumulates and replaces the normal functional cells of the organ. In the liver, this is cirrhosis. The hepatocytes are replaced by fibrous bands. Normal architecture is lost, and the liver can no longer perform its metabolic functions. In the kidney, it's chronic interstitial nephritis, leading to end-stage renal disease. Fibrosis is largely irreversible. This is why treating chronic inflammatory diseases early before significant fibrosis accumulates is so clinically important. Concepts to take with you. The one that I think matters most clinically is the last one. Fibrosis is irreversible. Once an organ has been substantially replaced by scar tissue, it's gone. The window for effective treatment in chronic inflammatory disease is before that happens, which means recognizing and diagnosing chronic inflammation early using the cellular patterns we've discussed today as your guide. In our next talk, we'll look at what happens after the inflammation resolves, how the body attempts to repair and regenerate damaged tissue, and why sometimes it succeeds and sometimes it fails. The video, read the question, try your hand at working the scenario, we'll work it together. This is Johne's disease, paratuberculosis caused by Mycobacterium avium subspecies paratuberculosis. MAP-like, all mycobacteria, has evolved multiple mechanisms to survive inside macrophages. The bacterium prevents the phagosome from fusing with the lysosome, blocking its own destruction. It also modulates macrophage signaling to suppress the oxidative burst. So the macrophage has ingested the organism but it can't kill it. The result is persistent macrophage activation, granuloma formation, and ongoing intestinal inflammation that destroys absorptive capacity, causing the protein-losing enteropathy that presents as diarrhea and weight loss. The acid-fast stain is the key diagnostic tool. Pause the video, read the question, try your hand at working the solution. We'll then work it together. This is a foreign body reaction, almost certainly to retained suture material or another surgical implant. The refractile material on cytology is the foreign body itself. The cellular response is a pyogranuloma, a mixed response of macrophages and neutrophils, typical of foreign body reactions with secondary bacterial contamination. The multinucleated giant cells are foreign body type, nuclei scattered randomly throughout the cytoplasm, not in the Langhans horseshoe pattern. The only effective treatment is removal of the foreign material. Anti-inflammatory drugs will suppress the response temporarily, but the reaction will recur as long as the stimulus is present. Pause the video, read the question, give it a try, and we'll work it together. FIP is driven by a mutated feline coronavirus that gains the ability to replicate efficiently within macrophages. Monocytes and macrophages are the primary target and vehicle of the virus. This macrophage tropism is key. Because the virus lives and replicates inside macrophages, the immune response is predominantly a macrophage and T cell response, producing the characteristic perivascular granulomatous pattern, where granulomas form around vessels because that's where infected monocytes are trafficking. The vasculitis component drives the protein-rich effusion seen in wet FIP.